Yeah, definitely. I'm a second-year medical student. I actually just finished my second year at Northwestern Feinberg School of Medicine. As part of our curriculum, we get to do a 4-year research project where we get to pick out a mentor and something that we're interested in. I was interested in anesthesia and pain medicine when I got into med school. So I found my mentor, Dr. Schnitzer, who is also an author on the paper as well, and he does his work in osteoarthritis and non-opioid prescription alternatives for that. And we wanted to take a look at osteoarthritis trends in different subspecialties, whether they be primary care or orthopedics or in the emergency department. But the problem we ran into was actually that each of those different subspecialties had a lot of different data going on and different ways they entered it into the emergency, the EMR. And so we focused in on the emergency department because that data was the best that was available to us. And that's because it's usually in-house system. And when you're ordering the prescriptions, it's on the computer in the room. And so once we focused in on that, we realized we had a gold mine of data because of how well it looked. And the emergency department's really on the forefront of pain management because they see about 20% of all, or they prescribe about 20% of all opioids by specialty in 2015. Up to 2/3 of patients come to the emergency room with pain. 10 to 16% of those are chronic pain conditions. And then obviously the biggest risk factor for continued and chronic opioid use is getting an initial prescription. And so limiting that in the emergency department is obviously pretty important. And so that's where we focused in.
Yeah, that's an interesting point. So Lewis Nelson, who's one of the authors of the invited commentary that came with us, when he gave grand rounds a couple of years ago at Northwestern, he makes the great point that you can't get addicted to opioids if you never have an initial exposure to opioids, which is one of those things that's, an obvious truism, but totally makes sense. Great. So tell us what you found here.
Yeah, definitely. So we wanted to look longitudinally over time. We looked from 2009 to 2018, and we saw that the peak of opioid utilization and prescription in the emergency department was in 2013. They prescribed about 9,400 opioids that year, which was a clip of about 16 patients per 100 or 16 encounters per 100. And then in 2018, that was down to about 5.5 patients per 100 encounters. So that's about a 66% decline over the last 5 years. That's a lot higher rate of decline than we see nationally, which is about 22% based off of large database sets. So it was really interesting to see that how well that this emergency department has done, including you. And we wanted to also look at different trends within not just osteoarthritis, but a lot of pain conditions. So we looked at musculoskeletal pain conditions, including back pain, joint pain, limb pain, neck pain, musculoskeletal trauma, fractures, contusions, sprains, other injuries, and then non-musculoskeletal pain. And we saw that the biggest decline was in musculoskeletal pain conditions like back pain and neck pain, most specifically. And we have multitude of reasons for that, but there was about 71% decline, which is greater than the 66% decline versus the other two pain subsets, which were musculoskeletal trauma and non-musculoskeletal pain, which are about 50 to 58% declines, which are obviously substantial, but less so than musculoskeletal pain. We also looked at demographics within the emergency department of the patients, seeing if there was a differential treatment of opioids within age, race, sex, and then also payer status. And then we also looked at individual providers because other studies have shown that certain providers will completely stop using opioids or really reduce their morphine milligram equivalents of opioids, and then some don't change. So we wanted to see, was this a joint effort within the department, or was it just a few that were dragging down the total average? And we found that, again, that all 12 providers in the study reduced their opioid utilization, the highest being about an 8.8 per 100 encounter clip in 2017, so no more than 9 per 100 by these top 12 physicians who were selected because they had the highest opioid use over the 10 years in the study. We also found that within race, we saw that Black and Asian patients were the least likely to get opioids, about 25% lower than white patients as the comparative variable. And then we also saw that Medicaid patients were the least likely to get opioids in the emergency department too.
Yeah, it's been really interesting. And I will say, casually, this kind of reflects a lot of my experience. I joined the department in mid 2016. And I'd say at the time, that's a little bit, I'd say probably looks about a third or halfway down the downslope from 2013 onward. But at the time, it was, pretty much any fast track patient with painful conditions, the threshold to get, a Norco prescription for 20 tablets was pretty low. The standard kind of treatment for acute pain was give 4 milligrams of morphine, which is a pretty low dose. That didn't work very well. So give a milligram of Dilaudid, which is, nearly twice as much in equal analgesia and morphine milligram equivalents, as well as, much more euphoric and more addictive. And I think that's one of those things where we have, a ton of data, a ton of pathophysiology, and, resonates with our experience that nobody comes to the ED asking for the one with the M. And so it's been really interesting just watching how much that's changed. Right. Was your team able to identify any reasons for any of these potential changes in trends?
Right. So in 2009, I think, is when people started recognizing the problem and things started coming out. I think things kind of get delayed. I heard a good quote the other week about the coronavirus, where if it's before the pandemic, anything you do is like whistleblowing or blowing things out of proportion, and everything after the pandemic is you're too late to join the party. So I think in 2013, we first start seeing some guidelines within emergency medicine literature. And then in 2016, we saw some CDC guidelines on opioid prescribing for emergency medicine. And then also within the department, I met with a few people that you're colleagues with, and they talked about a quarterly prescription monitoring where you guys compare your prescription rates to your other colleagues and seeing where you are relative to those. So I think that's what really drove down the substantial decline within each of the 12 providers, and not just seeing some change and some don't. When you're getting compared all the time and having quality initiatives for those, I think that's what really drives down the opioid utilization within the department.
Yeah, what's been really interesting about that quality improvement initiative is that it's a pretty weak intervention. We get anonymous data. There's no dollars behind it. We're not getting rated in any way. We're not getting judged. Nobody's getting specific feedback. We just kind of get told, hey, here's a curve, and here's where you fall along the curve, and do with it what you want. And we've all kind of seen the numbers go down. But I think it's just kind of part of how much the culture has been changing over the last number of years. I've mentioned this here before, but just it's been really interesting where I feel like I was in medical school and beginning of residency during kind of, I think, some of the peak of the oligoanagesia, like we're just not addressing pain is a vital sign. And then at the same time, seeing the big upswing of the concerns about the opioid epidemic. And so watching that pendulum swing has been really interesting. One of the things I found really, really intriguing in your paper is looking at the diagnoses. And you mentioned this, there's basically the non-traumatic pain, so like back pain, neck pain, which had huge drops. But even within the traumatic pain, the drops in sprains was pretty high, about 77%, but fractures only fell 46%. And then other things like kidney stones dropped 26%. So, I mean, to me, this resonates as, this is, looking at data and trying to I don't know, retcon in explanations, which is always fraught with peril. But, for things that we agree about as objectively painful as they can be, we're not deprescribing nearly as much.
Right. I think the important thing there is you have subjective pain and you have objective pain. When you see a bone sticking through a leg, you go, wow, that's painful. They should probably get an opioid, versus somebody who's coming in on maybe their 5th visit in the year because their back pain exacerbation problems. It's going to be a little bit less likely to use those. And then also, too, within the musculoskeletal pain, like back pain and neck pain, we have a lot of papers showing that NSAIDs and lidocaine patches are also just as effective, if not more effective, in treating those. So it's a lot easier to find an alternative versus kidney stones, perhaps.
Yeah, sorry. Go ahead.
Sorry, no, go ahead.
No, you go ahead.
I know. I was just going to say, just as an offhand comment, I love that 12 clinicians had more than 10,000 encounters in 3 years. To me, as a non-emergency medicine person, that seems like a really exorbitant amount of patients. So a lot of kudos to you, I guess, Seth, and all of your colleagues.
Well, it's EDs are busy. I think the typical overall, I think, average rate of patients being seen is like 2.5 an hour.
Yeah.
And then in a department like ours where we're supervising residents and APPs, it goes up a little higher. And I think all 12 had been, those numbers were, if I remember correctly, from like 2009 all the way through 2018. So those numbers add up pretty quickly.
You do over time. I wanted to ask one question about, and you alluded to this before. I was sort of surprised. I think, I know some of the literature around Black patients and Asian American patients having received lower doses of analgesics, just sort of in general. But I was sort of surprised to see it also translate to, even like at the height of when, perhaps not the height, but when more opioids were being given, it was like that differential still existed. But I can't recall, did that number, like among those patients, did that sort of trajectory go down over time as well?
Yes. So like you said, there's always been a little bit of discrepancy in pain treatment. We did look at the interaction of race over time as well with the decline. And we saw basically the same trend that you would find within just the overall prevalence, that within Black patients, they did decline actually at the highest clip as well over the last 5 years. Yes.
Yeah, I just happen to have it in front of me. The adjusted odds ratio is 0.78. So for a greater yearly decrease based on race for Black compared to white. I think some people have, I feel like, half snarkily said, oh, well, like the I don't know, implicit bias in pain control, and basically the implicit racism in pain control has been like protective against certain vulnerable populations. Right. I feel like there's too many double negatives in there, and that's like, people who don't have access to life-saving surgery aren't spared from surgical complications. Right. It's we do a bad job of controlling pain in vulnerable populations and underrepresented minorities and Black patients, et cetera. The fact that there happens to be this now double negative where we don't get them addicted to pain meds at all as much is like there's too many levels. It's I'm not as sanguine on that.
Yeah.
Yeah. All right, great. Well, any other final thoughts, Ben?
No, thank you guys for having me. I think the biggest thing I want from this paper is just a great description of what you could do. Obviously, the decision comes down to a individual prescriber in an individual situation. I've never prescribed a medicine in my entire life yet. I got a couple years to go, so I don't want to sit here and say we shouldn't prescribe these opioids to people who need them. But just to give a second quick thought to seeing if there's something else that might be just as good in the situation to avoid some of the long-term complications.
Yeah. Well, great. Well, this is fantastic work, and keep it up. Take care. Thank you for joining us.
Thanks for having me.
Great. All right. Next up, we've got another medication-related paper, The Incidence and Lethality of Suicidal Overdoses by Drug Class. This is by Ted Miller and colleagues. So this is interesting. Some of the background that's mentioned in the paper and in the invited commentary that so drug overdoses or intentional overdose is the most common type of suicide attempt. But it's only the third leading cause of death by suicide because only 2% of them are fatal. So in this study, they looked at state databases. They looked at a couple of national databases for clinical data, HCUP, NIS, NEDS. They looked at 11 specific states, but it accounted for about 35% of 35% of the U.S. residents' suicide attempts and drug suicides specifically. It was, I think, 2012 and 2016, they had over 400,000 drug poisoning suicidal acts with a total of nearly 22,000 deaths, mean age of 36 and a half, a little more than half were women. And the things that they found that were interesting, so basically trying to find the difference in drug classes and how fatal they were. So the opioids were about 5 to 10% fatal. Antidepressant overdoses were about 3 to almost 4% fatal. Barbiturate overdoses were 6 to 12% fatal, but I guess are used aren't prescribed nearly as much as they used to be, or as the other drugs anymore. And then the kind of other medications that contributed a bunch were things like diabetes medications and aspirin. But basically the things they found, there's a ton. This is one of those papers that's really worth reading because there's so much little nuance in here of just interesting findings and descriptive stuff. But basically for people who took an opioid as part of their overdose, they were 5 times as likely to complete suicide, and so with barbiturates, it's about 4 times as much likely as compared to all comers. And then a ton of changes in things like age and other demographics. Some of the conclusions are things like blister packs might be helpful. I believe Europe has kind of led the charge on this with acetaminophen, or as they call it, paracetamol for blister packs, because acetaminophen, it's terrible. It's one of those things where it causes a ton of acute liver toxicity and is a big cause of liver transplants. But if you have to sit there and punch out the little blister packs every time, that gives people, I guess, time to reconsider the suicide attempt. And as they mentioned, 90% or more of those who attempt suicide and survive don't go on to later, complete suicide. So it's little public health things like that. It's just like how we've gotten better about not keeping public health interventions about not keeping chemicals under the sink and stuff like that in housing
Right.
children.
I was sort of interested in so one, I thought this was very interesting, like you mentioned, but I think one of the figures that the authors note, or one of the findings that the authors note, is that 81% of suicides involving opioids would not have been fatal absent opioids, I guess. Mm-hmm. And I thought about, because I thought at one point they mentioned that there was a subset of patients that sort of the cause of death was listed as undetermined. And so I did wonder, particularly in the case of opioids, how many of these sort of overdoses were actually intentional versus unintentional. And I think sometimes it's probably hard to parse out, right?
Right. Yeah. I mean, there's so many issues with the data for stuff like this. And it's one of those, perfect is the enemy of the good. And we do the best we can with the data that we have to try to draw conclusions and, try to get better data. But there's so much that goes on. I was actually, a reporter just reached out to me earlier today trying to get some information on how the coding works for COVID deaths. And it's, I'm not an expert in that field, but from what I do know, it's just so all over the place that, or just assigning cause of death is so troublesome that it's hard to know, but we all do the best we can.
Yeah, no, definitely. Really interesting stuff. I was very interested to see the breakdown, actually, because there were things that I didn't think about. Although, I mean, they are things you learn about when you think about toxicology, I guess. But it was just sort of interesting to see how that ended up kind of falling into place or falling in line.
Yeah, absolutely. And the invited commentary that comes with this is really interesting. Makes a lot of really great points and things like potential interventions for people who, are having major depressive episodes or potentially suicidal, things like not necessarily taking away all of somebody's medications, but making it so there's less harmful amounts around and things like that. Kind of similar to things like removing access to firearms for people who at high risk. So sorry, I fell behind a little bit. There's a little bit of a technical glitch, but want to welcome Dapper Fett, Dr. Overseas, Navdeep Gupta, Aden Becerra, Ankur Kalra, James Murdoch, and Bernadette Keefe. Welcome, if you're still with us. Sorry about the delay. All right. Our next paper, we have the association between adherence to evidence-based practices for treatment of patients with traumatic rib fractures and mortality rates among U.S. trauma centers by Tignanelli and colleagues. So this is an interesting study. They used the American College of Surgeons National Trauma Data Bank, which is a really good registry of trauma data for the U.S. Looked at years 2007 to 2014, which included data from 777 trauma centers, patients in an average age of 51, and an average of 4.2 rib fractures, and basically looked to see of these 6 evidence-based practices from national guidelines from various groups, how many patients actually got these. The punchline is not a lot, and you can see this in figure 1, but basically only 4% received neuroaxial blockade, only 42% were admitted to the ICU, only 14% received surgical rib fixation, only 1% got pneumatic stabilization, which is a fancy term for non-invasive positive pressure ventilation, 42% received tube thoracostomy if they had hemo or pneumothorax, which is not terribly surprising, and 40% received chest CT scans, which is actually a little surprising that it was that low based on my experience in trauma centers. And this is a little interesting. Some of these, the nerve blocks, the ICU, the positive pressure, and the CTs, those recommendations are only for patients who are older and have 3 or more fractures, which is, pretty, I think, solid guidelines we've had for a while. there's a ton of variability in practice. A lot of this stuff, there's another figure that shows just how much each individual hospital varied across this. And it's not terribly surprising. And I think one of the things that's most interesting here, the invited commentary gets into a lot, is how low the level of data is for all of these interventions. And we really just haven't answered all of these questions very well, if they're good or not. So the fact that this stuff isn't terribly well complied with is not necessarily a bad thing.
I have to say, I thought this paper was fascinating. Again, as somebody that's not in, this isn't my field. And I had so many questions for you actually when I was reading it, because I was thinking about the fact that, you mentioned overall the rates of a lot of these things are quite low, but I did wonder about this, potential association. Like, for example, I think they found that pneumatic stabilization was associated with an increased mortality in patients that were older and had 3 or more rib fractures. And so to me, obviously we can't say that they're completely associated, but I did find that to me kind of made sense. But I did wonder about things like neuraxial blockade. I don't know if this is something that you have done or do, or who would do that, but
yeah. I mean, I've done rib blocks before, and people have talked about doing things like rib blocks. I haven't seen a lot of epidurals for it. Yeah, it's interesting. I mean, that being said, I don't know. I'm not, my clinical experience isn't what happens to these patients once they're upstairs. Right. So that's a lot more plausible. To see, anesthesia come to the trauma ICU and do blocks for patients with substantial injuries. It's just interesting. I don't know. It's, yeah.
Do you feel like you have seen or heard of, I guess maybe not seen, but again, because this is probably happening elsewhere, but heard of a lot of these things being used? Or, I wonder, is it pretty variable? And they looked at, I think, 777 trauma centers, right? Level 1 trauma centers in the U.S. Yeah. So I would surprise if there was quite a bit of variability, I guess.
Right. Yeah. And again, figure 2 kind of graphically shows how much variability there is, which is not at all surprising. But yeah, I mean, I was so surprised that only 40% got tube thoracostomies, chest drains for pneumo and hemothorax. If anything, I think we probably overtreat, not undertreat those. I was surprised how few got chest CT scans. I mean, the chest CT for 3 or more rib fractures, I mean, that's been ATLS for forever, or at least as long as I've been doing ATLS, which is, I think, 4 versions ago. I mean, if anything, I think we have this paradox now where most of the time, if I find 3 or more rib fractures, it's on the CT they already got, not on the chest X-ray. And that's
right.
And it's been such a switch too, because a lot of these radiographic findings of that might portend more deeper injuries, things like 3 or more rib fractures, scapular fractures, sternal fractures, first rib fractures. Those were all kind of axioms that came out of plain radiography, just regular X-rays. And now those are injuries we usually find on CT scans. When you've already done the CT scan, you don't need to go look for more injuries. But it's this weird mental, switch that's hard for sometimes on the ground. We're like, wait a minute, you've got this thing. It could be bad. Oh, wait, no, we found it on the thing. It's okay. This reminds me of a conversation I saw a couple years ago about implementation science and how, there's this double-edged sword where, we know all about the knowledge translation gap and how long it takes to get, good evidence into practice. But, it would be, if we there's a lot of times where we have mediocre or not great evidence. So, if we were doing things like really aggressively using, I'm going to pick on surgical root fixation, my understanding is the level of data for that is terrible. And a lot of it's just kind of change in practice and expert commentary, expert opinion that we don't really know that is helping people. So if we, made this big national push to get everybody with 3 or more rib fractures to get the ribs fixed, is that actually going to be helpful? I mean, sorry, I forgot. In this paper, it was specifically for flail chests, which makes a lot more sense. But, there's just an RCT that came out about, pretty decent sized pneumothoraces don't actually benefit from chest drains. So, which is, going to be a big paradigm shift for a lot of people, including me. I was surprised when I first saw the paper. First thing I did was look to see how they quantified it. I was like, wow, they were actually for big pneumothoraces, not for little ones.
Right.
Yeah. So
Interesting. I like, we've had a couple of these papers where they've kind of looked at guidelines and, how they're being implemented. And I do just find it to be very interesting, just how much, we've talked about variability, but also just how the data is still, it's confusing and there's a lot and things are shifting around constantly.
Right. And I think one of the best quips I've heard about guidelines, I want to say it's from Cliff Reed, is that clinical guidelines shouldn't replace good clinical judgment. They should replace bad clinical judgment.
Mm-hmm.
And, sometimes in papers like this, it's hard to suss out, a lot of patients who on paper, can look sick and can get these kind of data sets are actually a lot less sick than they may be. Or this is the one thing, or it's isolated, or, it's all very interesting. But,
yeah, definitely.
All right. You want to take us through the last paper?
Yeah. So this is by DeRoche and colleagues. It's the views and experiences of clinicians sharing medical record notes with patients. This was really, really interesting, and because I think it sort of speaks to or reflects a new reality that a lot of clinicians are being confronted with now in terms of EHRs. And I think the background would be a lot of health systems are now making clinical notes available and open to patients to be able to kind of go back and review. So the objective of this study was actually to try to look at or assess clinician views on this practice of sharing open notes or clinical notes, open notes with patients. So this was a web-based survey of physicians, advanced practice nurses, PAs, therapists at 3 health systems. They had about 1,600 people that responded. The respondents were more likely to be female and to be younger. Most were physicians, and most spent less than 40 hours per week in direct patient care. And actually, most of the respondents viewed open notes positively, with 74% of respondents agreeing that open notes are useful to engage patients, 61% recommending this practice to colleagues. The one sort of interesting thing I thought about one of the questions was that 37% of respondents did report that this practice did require them to spend more time on documentation, particularly, I think, surrounding language and just sort of how to present information, knowing that it's going to be read by patients at a later date. So sort of interesting because, the sparse literature that I've seen or heard of looking at open notes, or maybe I should say the sparse conversation surrounding it, I think has been really mixed. And so it was sort of nice to see a paper that kind of addressed that from, the clinician perspective.
Yeah, I found this really fascinating. And I feel like this is one of those things where I feel like it's really easy for clinicians to get really defensive about this stuff early on. And I will tell you, the first thing I did was search for kind of the potential for negativity in notes and things like that. And it's in table 4. And there's, use of language that could be perceived as critical of the patient, or documenting sensitive information, or terms like non-compliant, or patient refuses, or patient denies, or even little things. Like I remember in med school, we had a session on ethics and legal stuff around charting and patient access to it. And, patients absolutely have access to their notes. But there's forever hospitals have been able to kind of throttle that in certain ways, not necessarily control access, but make sure it happens in a controlled way. Mm-hmm. And there's a lot of things that are absolutely not judgmental or patronizing or anything like that. But if you put FUSOB in a note, that means something very, very different to a clinician and somebody without knowledge of medical abbreviations.
Yes, yeah, definitely. There's a lot of nuance there, I guess.
Yep, absolutely. But I mean, ultimately, it's good. I think it's even these little kind of protective things or concerns about prior restraint or whatever in notes is, to me, pales in comparison to just the status quo ante of just we do a terrible job of giving patients access to their notes, which are about them, which are by definition their property. It's the patient's health. The patient's the one with the disease, not me. Yeah. So I think it's good to see how positive some of these opinions were on here.
Yeah, I think so too. And I have to say, from the perspective of for me, having been a patient, having access to the notes has actually been really helpful because it keeps you informed, right? It's hard to keep all of that information together after a 30-minute or however long of an appointment. And so it's nice that people, the clinicians also appreciate that there are a lot of benefits.
Yep, absolutely. All right. Well, I think that's it for the papers this week. Thank you, everybody, for joining us. Of course, you can get the author interview portion of this will be up in iTunes in a little bit, and you can, or wherever you get podcast, tune in with us next week. We should be back to Tuesday, 3 p.m. Central Time. Get these papers and more free and open access at jamanetworkopen.com, 10 a.m. Central Time every weekday. New papers are coming out, and follow us on all the usual social channels. And of course, stay safe.
Thanks, guys.